Hello, and welcome to the webinar, AOT Impacts and Opportunities for the Hospital Emergency Department. Today's event is part of a series of webinars hosted by the Center for Behavioral Health and Justice at Wayne State University School of Social Work as part of the development of an assisted outpatient treatment toolkit. My name is Scott Smith, and I'm a technical consultant for the Center for Behavioral Health and Justice. But I also play a few other roles. I'm on staff at formerly known as Beaumont Royal Oak, now Corewell Health. I've been on staff at their ER for 13 years, and I've worked in emergency departments in 3 states over the course of most of my 22-year career. I'm a professor of social work as well up at Oakland University, and I teach in the medical school at Oakland University. AOT is something that has been very important to me, and I feel honored to be a part of this broader process that the state and the Center for Behavioral Health and Justice are conducting. I want to provide you with a little bit of background about assisted outpatient treatment because today's webinar is specifically for emergency departments, and we have a broad audience of both emergency department clinicians and administrators. I want to make sure that we're all on the same page. With AOT, what we're really talking about is an opportunity to intervene with someone who, as a result of their mental illness, is not able to recognize that they're ill and may experience other barriers to being able to manage their symptoms. As a result, we know that many individuals who are living with serious mental illness really end up with a lot of adverse outcomes. We see a lot of them in our emergency departments. AOT was designed specifically to help individuals living with a serious mental illness who, as a result of their non-adherence, are at risk for myriad negative outcomes. And the way that AOT tries to help address this is by compelling the recipient to receive specific treatment that will prevent their condition from worsening, but also by committing the mental health system to provide that treatment. Again, today we're going to focus on why assisted outpatient treatment matters to emergency departments. In the future, we're going to be having webinars that will address where AOT might be helpful more broadly within an acute hospital setting for individuals who are on medical floors, for individuals in a psych unit contained within a medical facility. But for today, we're going to specifically focus on the domain of the emergency department. Now, as I just mentioned, assisted outpatient treatment is available to adults living with a serious mental illness who don't understand that they're ill and that they need treatment. This is sometimes referred to as anosognosia, that are unlikely to voluntarily participate in or adhere to treatments necessary to keep them from harm. And similar to interventions like inpatient psychiatric hospitalization, that is petitioning, inserting a patient to be involuntarily hospitalized, they have to have primarily a mental illness. This can't be exclusively the result of substance use disorder or a neurodegenerative condition such as dementia. And that because they're not receiving their treatment, because they're not adhering to it, they're likely to have a deterioration in their condition, which could result in harm to themselves and/or others. We know that untreated serious mental illness is a significant contributor to many of the problems that we're experiencing as a result of the increased need for mental health treatment. Suicidal and self-harming behaviors being among the primary ones. The risk for suicide, obviously, among individuals living with a serious mental illness is quite elevated relative to other individuals with mental illness. We also know that the majority of people experiencing homelessness, housing insecurity, or instability, that they're living with a serious mental illness, either undiagnosed or untreated. Unfortunately, while most people with a serious mental illness are not violent, we do know that when violence does occur, it's often related to someone who has the serious mental illness and is not receiving the treatment necessary. This all collectively leads to a lot of contact with law enforcement, frequent inpatient psychiatric hospitalizations, and high utilization of EDs. And on a personal note, as somebody who's in the ED and who gets to see what this look like, I understand it's been a rough few years. I've watched over the past decade really as just the numbers of individuals with serious mental illness have been flooding into the EDs because people didn't know where else to turn. And I know that while we're all grateful for the opportunity to help them, to serve our communities in this way, we all also feel that frustration that the ED is just simply not set up or designed to provide what these patients need. And I'm especially encouraged today that I think we can see a lot of our concerns, a lot of the challenges we're facing from the ED perspective, potentially addressed with assisted outpatient treatment. And I want to be careful to not oversell this, to not make any promises that this is going to be a cure-all or a panacea. But later today, when our panelists join us, we're going to have the opportunity to really hear from some professionals who are experiencing benefits from assisted outpatient treatment being used in their community. And they're going to get a chance to share with us a little bit about what they're seeing, especially as it relates to the emergency departments. And when we talk about emergency departments and the way that they've become the de facto treatment facility for many individuals who are living with serious mental illness, we know that the housing instability piece we talked about that's so common for individuals living with serious mental illness, that this is one of the big causes of that increase in emergency department utilization, right? For example, individuals that we might believe are malingering, those that we recognize are there because it's especially hot or cold out, there's no shelter space available, the bed and breakfast crowd, as we sometimes refer to them. And then more broadly, the fact that they're not just disconnected from mental health treatment, they're also not connected to any form of treatment. They have no primary care provider to really help coordinate services. In addition, because of their increased exposure to violence and substance use, we see them in the ED for non-psych related issues as well. Interestingly, we actually in the emergency department see individuals who are unknown to the community mental health system, specifically because of what happens for somebody when they receive that designation of serious mentally ill. Many of them will then qualify as being disabled and receive benefits, among which Medicare is one. And now because they have Medicare as their primary payer, they are not the direct responsibility of the CMH. And believe it or not, many of the individuals that we see often are familiar faces in the emergency department are simply not on the radar of CMH, which really makes it difficult for any type of coordination of care. And as a result, they become heavily reliant on the emergency departments or emergency departments to inpatient hospitalization for their psychiatric care. Add to that, emergency departments have become the default location for law enforcement to drop individuals who are dealing with a mental health crisis. Many communities are developing crisis drop-in centers, and that's been a very positive move, but there's still a heavy reliance on emergency departments. Because of laws like EMTALA, emergency departments can't turn away anybody. And as a result, there's huge cost expenditures associated with this large, seriously mentally ill population that the EDs serve. So not just the high ED utilization overall, but we're talking about the extended ED stays and the fact that they're not being reimbursed. Not only are there longer stays in the ED, but we know that the staffing needs grow exponentially because very often you're going to need to assign sitters, one-to-one sitters, maybe have more security present. Nursing staff who have their maximums for the number of patients they can be working with at any period of time, well, you're going to have to bring in more nurses. Often that's a challenge under normal circumstances. Throw in a pandemic and a shortage of nurses, And now we're talking about both a logistical issue from just having the staff, as well as a financial burden. All of this collectively is a big reason why we see a lot of staff burnout and decreased employee retention. Can AOT help with this? I believe it can in the long term, and I'll discuss a bit more of that later on. I want to give a special shout out to the Michigan Hospital Association and Laura Lapine, who's been instrumental in helping me connect with many of you in different parts of the state to get a sense of what you're seeing and what challenges you're facing as we were developing this section of the AOT toolkit. And this has been one of the more consistent things. I know that even as someone who loves the emergency department, who loves crisis work, that when you see the familiar faces and you see that things just don't seem to get better, that leaves you feeling frustrated, leaves you feeling like maybe you're not effective, maybe you're not doing what you want to be doing. And when you spend a lot of your time on these cases, it makes you question whether this is the right fit for you. So I think, again, burnout, employee retention, both heavily influenced by this. Now, obviously, many of the same challenges that impair somebody's ability to comply or adhere, that is, to treatment, also presents challenging in even getting them registered. So the little that we can bill for in the ED is often impaired because we can't get an identity, we can't get a name, can't find them in CHAMPS or any other payer system. And obviously, collectively, this all leads to the increased bad debt charity care, for which EDs carry the largest burden of that in any hospital system. It's been tough. I think that there's good news on the horizon. I really do. Now, another area where AOT is particularly helpful with what EDs are trying to do is that the push that JCAHO has been having in recent years around doing a better job of addressing health disparities, AOT can be a big part of hospitals' plans for meeting some of those ever-expanding goals. Notably, many of the fundamental causes of health disparities are actually directly linked to serious mental illness. And it's the things that we've already been talking about, right? The housing instability, co-occurring substance use disorders, limited social support, limited access to care, their impaired judgment, recognition of illness, many of their symptoms related to treatment and receiving treatment, adhering to treatment, not just for mental health, but for physical health as well. And by the way, all of these factors are especially burdensome in light of the ACA's requirements around readmissions. As I mentioned, individuals with Medicare primary, many individuals with serious mental illness have Medicare primary. Well, those individuals, we know if they have, readmissions within 30 days, the hospital is going to be penalized for that, actually reimbursed less because of that. So the health inequalities that contribute to poor health outcomes, that increase the burden on the hospitals, EDs, and the rest of the acute care environment, the reimbursement, all of this does come back to many of these same issues that AOT is actually uniquely set up to try to address. Now, what AOT can potentially do and what it can't, starting with what it can. It can address the lack of established outpatient treatment that leads to the reliance on EDs for both physical and behavioral health. That is something that AOT is in a good position to do. And in just a moment, I'm going to give you some examples of what's happened in other states utilizing assisted outpatient treatment and what kind of reductions they've seen. We know that by reducing contact with law enforcement, we would expect to see a result in a drop in the number of EDs visits because of ED drop-offs by law enforcement. When substance use disorders are addressed, and that's a unique feature of assisted outpatient treatment we don't see in involuntary hospitalization, is that we can address those concurrent problems, those comorbidities. So we can not only, recommend care for the mental illness piece, but also for the substance use disorder. also for managing their physical health condition, the way that that influences it. And by doing that, we know that that's going to lower the number of individuals that we're seeing because of the exposures to violence, injuries, the higher rates of infectious disease, unfortunately, that's more common. The frequent mental health crises, all of these things can really be decreased by AOT when it's used overwhelmingly consistently and when there's a good integration within the community. And beyond just those direct benefits are the things I already mentioned. When staff are able to focus on what they want to do, why they got into emergency medicine. And I hear this especially from ED attendings all the time, from the residents, that they got into emergency medicine to, be George Clooney, to be Dr. McDreamy, to do those exciting, fun things that we see, popularized on TV and any of the emergency department shows. And they're often frustrated when their entire patient load that day are psych patients and they feel like, I can't do anything because we're literally just waiting. So when familiar faces are a bit less familiar, we know that that does improve overall satisfaction among staff, which is a big contributor to retention. It also is going to allow those of you who are making the staffing decisions or are faced with the staffing decisions to be more effective in your allocation of existing staff, right? Tech, security, your RNs, your psychosocial workers. You can put them where needed as opposed to having the need dictate where you. And we will see less unreimbursed care. Don't want to oversell that piece, but with fewer long waits in the ED for inpatient psych placement, especially that process that's referred to as boarding, we know that that's going to really directly benefit the ED. And it's important at this point for me to point out that a little later on, I'm going to tell you that, yeah, this is going to require potentially some changes in the way you do things if you want to utilize this. However, another thing I'm going to point out to you later on is that you're going to benefit substantially. In fact, you will have a relatively high return on any investment of time relative to the other systems involved in this process. So I think that's some really good news for emergency departments. The other piece that emergency departments are vital for in this broader AOT process is what I mentioned earlier. That is helping the CMH system recognize individuals who need care. And this happens not just with those individuals with Medicare that we talked about, but also the individuals that we see usually intoxicated or under the effects of some other substance that's masking their serious mental illness. So as far as most people are concerned, their primary SUD, when in fact it's a comorbid condition. And I also think that emergency departments can play a vital role with the identification of new onset of serious mental illness. We know that for individuals, especially those living with a psychotic disorder of some type, schizophrenia, schizoaffective disorder, for them, diagnosis and starting treatment in that early phase of symptom emergence, that first 18 months, is highly correlated with having a good prognosis. We know that it's more likely to result in retention of their support system. It's more likely to result in actual treatment adherence. And really, the thing that we all share in common today, regardless of our role, our desire to help people live healthy, full lives. So I want to talk now about what AOT actually looks like when it's in action. AOT in Michigan can cover a wide range of services, and I won't read through this list. And as a reminder, this webinar is being recorded and will be available on our website for your reference in the future. But the services that are available to AOT are extensive and also include whatever a particular treatment team believes is necessary. This is where things like the primary health providers, the PCPs, can be so, important for managing your overall mental wellness, your mental health, your serious mental illness. And that can be something that AOT helps to coordinate and ensure is happening. We see a lot of the biggest benefits from things like the use of medications, especially long-acting injectable formularies, where we take the daily adherence to medication off the table. And what we find, in fact, from many individuals placed on long-acting injectables, they actually prefer it. They actually prefer that form of medication administration. But there's a lot of services available, and the broader ability for somebody to recommend services that aren't explicitly enumerated. Now, again, AOT is not a cure-all, and research around AOT, well, we've learned that some people are going to benefit more than others. Typically, individuals who are younger are going to receive more benefits, especially because we know that there are, unfortunately, learned behaviors that many individuals living with serious mental illness adopt, often as a survival mechanism to get their needs met, but these don't respond as readily to treatments. And the older somebody is, the more ingrained these behaviors are, the more difficult they are to treat. By far, AOT really has its best effects with those living with a psychotic disorder of some type, or a condition that frequently has psychotic features that really become the primary barriers to treatment adherence. And this is largely because of the ability to potentially use medications like, long-acting injectable formularies, something that's much easier to administer, control, and monitor. This does tend to work best for individuals who are not adhering to treatment because of either that lack of awareness or symptoms like paranoia, grandiosity that are impairing their treatment adherence. It doesn't work as well for individuals who aren't adhering just because they're ambivalent. They don't feel the need. It's not going to create a sense of urgency or any motivation to engage in treatment necessarily, although that can be something potentially addressed in some situations. And obviously then it's going to work best for someone who doesn't have any contraindications, especially to medications like antipsychotics. For individuals who have demonstrated the life skills to sustain housing and employment prior to the onset of their illness, they're good candidates as well. And this is a good point to note that some individuals, especially those that don't have this aspect, this life skill established, they're probably better suited to guardianship. And guardianship, in Michigan is something we actually use very often. And I know from the ED side of things, it creates a lot of challenges as well. I've also been seeing a lot of the court-appointed guardians dropping many patients in recent months, and it's becoming harder and harder to find guardians. AOT is not a substitute for guardianship. It can work with guardianship, and it might be a better starting point. That's something that we have covered in some of the other webinars, and we'll be covering more in depth at other times. But as a note, guardianship is still another important consideration in this process. Now, let's talk about why I actually am, more broadly speaking, very encouraged by assisted outpatient treatment's ability to be beneficial to AOT. New York has had assisted outpatient treatment running the longest of any state, and therefore it's the most studied. And as a result of that, I'm going to share those findings primarily because that's a lot of what we have. The typical individual in New York who was placed on assisted outpatient treatment had this kind of profile. 71% of them were diagnosed with a psychotic disorder. On average, they had had 3 inpatient psychiatric hospitalizations in the 6 months prior to being placed on an assisted outpatient treatment order. Half of them, roughly, were not adhering to their psychotropic medications, and about the same number had a co-occurring substance use disorder. 1 in 3 had been arrested, and 1 in 5 had actually been incarcerated in the 6 months prior, and about 20% had experienced recent homelessness. Now, after assisted outpatient treatment was implemented, what did they see in New York in terms of reduction in some of the behaviors that we're concerned about? Well, suicidal behavior, there was a reduction, 55% reduction. And imagine just the net benefit to you in the emergency department from this type of reduction. If you saw the number of individuals in your ED for concerns around suicidal behavior cut in half, think about just the amount of time savings, the staffing savings, the savings on one-to-ones, right? Our dear friends at JACO are pretty insistent on that, are growing more insistent every day. And so this is a huge asset in terms of personnel, in terms of pragmatic application of best practices. This alone is a huge benefit, but it gets better. Homelessness reductions doesn't really do it justice, because what New York saw was a 74% reduction in homelessness. And the one thing we know about individuals who are experiencing unstable housing, homelessness of some kind, they can't follow up with appointments because their provider may no longer be accessible because they've couch surfed away from that provider. It's hard to establish care. If they do have, Medicaid, well, maybe their Medicaid is, in a different county, and that can create some challenges. All this to say that by reducing homelessness, we would expect health benefits across the board and a lower burden on the ED. Inpatient psychiatric hospitalization, because of the medical clearance requirement in Michigan. And again, I'm very encouraged. One of the people that's been really helpful in providing feedback, Dr. Pelzer-Jones, I know that she's been a part of a work group looking at ways to improve this process, and she's reported a lot of encouraging progress on that. But we still have the burden to do a basic medical clearance for individuals needing inpatient hospitalization. Well, by reducing inpatient psychiatric hospitalizations by almost 80%, you're going to reduce the number of individuals that are coming through the ED with especially that need. Now, we know that substance use disorders for individuals with serious mental illness, over half have a concurrent SUD. We know that that creates a lot of challenges and barriers when we're trying to provide treatment. We have legal requirements around assessing somebody once they're sober. And then add to that, there's a risk of withdrawal. They're sitting in our ED for a few days while we're employing some type of protocol to either establish they're not going into withdrawal, or that we're managing, especially for alcohol withdrawal, those symptoms, because a standalone psych facility can't. So any reduction in their substance use is going to be a big improvement for us. And guess what? AOT is helpful here as well. About half of the individuals who were placed on assisted outpatient treatment order, and one of their services was substance use disorder treatment, about half of those individuals had maintained sobriety 6 months into their treatment. That's powerful. And obviously, because of the way that the ED serves as kind of this hub in many ways of contact for individuals with mental illness and other systems, any reduction in contact with law enforcement is going to be a benefit. And what New York saw was substantial reductions. Arrests were decreased by 83%. Violence, both actual and threatened and towards property, were all decreased between 43 and 47%. And this is obviously a pretty significant benefit for EDs as well, because this translates to safer environments for our staff members. So what are the considerations that emergency departments need to have around assisted outpatient treatment and its potential to be viable? Well, yes, there are going to be some practice changes. Now, the good news here is that this will not necessarily have to be a big change in practice. In many ways, what you're already doing probably just needs some tweaking. So, for instance, to petition somebody for assisted outpatient treatment, you use the same form that you've already been utilizing for petitioning somebody for inpatient psychiatric hospitalization. There's a webinar we've recorded and is being edited and uploaded to the hospital section of the Behavioral Health Justice Toolkit website as we speak. In that webinar, I go over the process of completing the petition for AOT and completing the petition in general. One of the things that we wanted to provide to you as hospitals was help for some of your staffing and training needs. Feel free to use that webinar once it's up as part of your onboarding process, because it's going to cover how you complete a petition, how you want to double check and coordinate with the cert that's being completed as well. And you'll get a lot of great tips there for how to make that happen with AOT. But because it's the same form, it doesn't necessarily result in a lot of a change for you as the emergency department. What will potentially be a change is that you'll need to maybe more formally identify those familiar faces and consider the appropriateness of AOT. Again, it's not going to work for anybody. And most of us who work in an emergency department could list off 10, 12 names from just the top of our head who we see quite frequently. It might be helpful to identify a point person who can not only talk to the ED staff, but also maybe care management staff, because there's going to be a lot of overlap, and maybe come up with a list and then find a way to flag them in your medical record keeping system. I did this training with my system last fall, and they talked to the people at Epic and were able to put some great little tools and flags in place so that the next time the individual would, for example, present to the emergency department, we could know that this is somebody we identified, and if it's appropriate, you can actually do that process then, either for assisted outpatient treatment only, or a combined order if during our assessment we determine that they do need hospitalization today, but we would like to help this person have a better life, so we're not just requesting inpatient hospitalization, we're also requesting that there be an evaluation for AOT. And one thing to be very clear about, as the emergency department, you're not doing that evaluation. You're simply considering the appropriateness of AOT and recommending that the job of evaluating whether the person is fit and meets the criteria for assisted outpatient treatment order is going to be handled, by the courts in close coordination, obviously, with the CMHs or with a private provider when that's the appropriate step. The one thing you'll do differently that you're most likely not doing now, you're going to file petitions directly with the court. Now, I understand that our typical process for somebody we're sending out is that we send the petition with the person to the inpatient facility. And we do that obviously because of EMS's requirements around having a petition insert, but we also do this, again, to communicate with the inpatient facility as a way to ensure that the court is being made aware and that nothing maybe goes awry at the inpatient level of intervention. By filing the petitions directly with the court, which in many areas has gotten much easier as a indirect benefit of the pandemic and courts needing to change the way that they operated. By doing it directly with the court, you're going to have a greater likelihood of the court actually seeing this and now initiating the process on the court end to consider this. So that's going to be that biggest change. A couple final points before we move on to our panelists. Again, you're not doing the AOT evaluation, you're simply recommending the evaluation for AOT. And as always, careful consideration of who this is most appropriate for. In the same way that we don't want to weaponize or overuse involuntary inpatient admission, we don't want to do that with involuntary outpatient treatment either. So we want to make sure that the individual is actually likely to benefit from that. We don't want to overburden the courts. We don't want to flood the CMHs with more cases. And we don't want people to kind of perceive that, frankly, we're just trying to use a paperwork solution to this. carefully consider whether or not they would. And again, those guidelines are helpful, and we'll be posting more tips and suggestions on that process at a later date. The familiar faces to you, again, are not necessarily familiar to anybody else in the treatment world. We've already recognized this with the criminal justice system, that they're seeing a lot of people that aren't being seen, in the mental health world. Same thing, especially with emergency departments. You really have an opportunity to serve them and the community in a meaningful way. And finally, for those individuals that you frequently see who are intoxicated, and you end up discharging because once they're sober, they no longer meet that criteria for inpatient admission, this is where you have an opportunity to do more than the traditional referral process. By submitting a petition to the court for assisted outpatient treatment without hospitalization, meaning you're not requesting the person be hospitalized now, don't think that they need it, you can actually initiate a screening process by the mental health treatment world to see if this person is in fact a good candidate for AOT and can address a co-occurring, disorder. So finally, when you may have to testify in some of these cases, and I get that this is another time commitment and it's hard with shift work. Just want to remind you that the state is moving to the best practice of testimony via Zoom. So I do think that this will come with minimal intrusion. And again, ED staff are probably much less likely. I know that I very rarely get, requested to appear at a hearing, in part because as medical personnel, it's harder to challenge really our assessment piece relative to family law enforcement. So I want to now introduce our esteemed panelists who are going to be taking your questions that you've submitted. And by the way, continue to submit your questions throughout this process. Joining us today, we have from Calhoun County, Dr. Sean Field, who's the clinical director from Summit Point CMH. Prior to joining Summit Point in 2016, Dr. Field worked as a member of Western Michigan University's behavior analysis team, as well as a contractor conducting autism evaluations in consultation with the Summit Point Autism Center. He is a board-certified behavior analyst at the doctoral level, BCBAD designation, a licensed behavioral analyst, and a limited licensed psychologist. Dr. Field has worked in a wide range of clinical settings, including schools, residential facilities, community-based programs, core programs, as well as outpatient mental health settings. Dr. Field has also served in a variety of oversight and advisory committees throughout the region and state related to behavioral health services. Also joining us today from Genesee County, we have Jenny Kimmel, the certified clinical supervisor of the AOT program at Genesee Health System. With over 14 years as a licensed social worker in various mental health organizations, Jenny's a passion for working with individuals with serious and persistent mental illness and diverting high-risk individuals to outpatient treatment rather than hospitalization or incarceration. And finally, from Wayne County, we have Sojourner Jones, who's been working in the mental health field for over 25 years. She currently serves as the community liaison for law enforcement with Detroit Wayne Integrated Health Network. Sojourner's role is to assist law enforcement and the courts to address behavioral health needs of those who come to the attention of the criminal legal system. She works to resolve structural issues, communication glitches, and persistent patterns between law enforcement, courts, and community mental health providers to improve treatment delivery. And I want to thank again all of our panelists for joining us today, and go ahead to our Q&A. And our first big kind of question, and one of the points that I actually had just addressed, but I recognize this is a very big shift in practice, is how realistic / feasible it is for emergency departments to actually file petitions and do this in a way that doesn't overburden staff or essentially create additional work that may not have benefits that we all really hope they will. And for this first question, I'm going to actually ask Jenny Kimmel to maybe respond first. Jenny, for what you've been doing in Genesee County, how would you respond to these concerns about EDs, them being the source of actually filing petitions with the court, and what may be helpful to consider in this?
I think that the most helpful thing to consider is that if we can successfully get an AOT on an individual and engage them on an outpatient basis, it's going to decrease the chances of them coming back to your emergency department. And therefore, that will reduce the work that you would have to do and free up the time for treating other individuals that might need it. I know that it might be extra work to fill out the petition and coordinate with the CMHs, but I think that in the long run, it'll be the best outcome for the individual, and it will result in actual more time being freed up for you.
Thank you. Dr. Field, I'd love to hear from you. What do you think about this process, the viability? What have you seen?
Yeah, so I will say that we have a bit of a unique situation in Calhoun County because we have our First Step program, which is a 24-hour psychiatric urgent care. So if there is actually someone at the ED that would require an AOT, but doesn't meet criteria for inpatient placement, they actually connect them back to us and we facilitate the petition. We do have a team that will respond to the hospital and work alongside their social workers and their physicians to assist. But more often than not, we are seeing those individuals brought back to us at our psychiatric urgent care, and then we do those petitions. So we definitely saw the challenge with the ED trying to execute that workflow and get that evaluation done. And we just changed our relationship with them so that we're right there alongside them, so that they can do their part in identifying the customers and connecting back to us. And then we work with the court to move those steps forward.
Thank you very much. Sojourner, what would you add?
Well, in Wayne County, we have a unique opportunity because we actually have a behavioral health unit within our probate court, who is actually, their whole goal is to assist and monitor to ensure compliance. And so I understand, especially in Wayne County, the volume that we have of those EDs and taking the extra steps to even file. But for Wayne County, they just want you to file. And for a majority of the members who don't need a higher level of care or at one point did, you already have the paperwork. So they're just asking that you submit the paperwork on to them, and then they can follow up with the CMH or even with Detroit Wayne to get the AOT started.
Thank you. And I do want to acknowledge that, some of you have shared concerns that this is obviously a big change and has implications, and that your legal departments would need to weigh in on this as well. And I appreciate that. I think it's very encouraging to hear from both Genesee and Calhoun counties how that process of the CMHs coming to the EDs, and that could be a great model moving forward, because obviously that does, the process of submitting a petition from the ED is really a big change and potentially burdensome and fraught with legal minefields. I know that one of the challenges we do face, though, especially for individuals who aren't being also hospitalized, if we discharge them from the ED, obviously we have to rely on that member to follow up with services. And again, we're talking about individuals who may not, because of their mental illness, be able to do that follow-up. So again, this is an area that we need to be in more dialogue with. And I appreciate all the feedback that the audience has given in terms of their thoughts and questions around. Another question that has been coming up has really involved training. And several participants have asked where they can get more training, how they can become more familiar with AOT, with more of the nuances, with best practices, with the treatments that are evidence-based that might be helpful for the population who would be candidates for AOT. And actually, Sojo, I'll start with you on this question. Where can people look for training?
Detroit Wayne, along with the behavioral health unit from Wayne County, along with Wayne State, CBHJ, we started conducting trainings, I think last year. In last year, in 2022. Yes. And so we first started with any CRIS provider. Then we also went to our crisis stabilization units and psychiatric urgent cares. And then we went to the inpatient facilities. So we have done ongoing training. We're in the process of revamping it. Because again, this is an evolving process and we understand there is a learning curve. And so we had to stop and reset. And so look out in the future. But in the meantime, I suggest you check with Wayne State's website. They have done a couple of webinars regarding to law enforcement. They're doing this one today for family members, etc. Also, I refer you to the Advocacy Treatment Center. They talk about ALTs. I will refer you to Genesee Health System with Jennifer, who is the queen in the state for doing it. And so it is an ever evolving process and it is a tool. There are no criminal procedures or anything for someone who is not compliant with ALT. It's just an additional tool to engage this difficult population who have complex needs and has gone through the revolving door of inpatient and never following up with outpatient services.
Thank you, Sojo. Dr. Field, what would you add?
I'll mirror a lot of what Sojo said. So we used the Treatment Advocacy Center TAC pretty consistently over the last few years. We've reached out to Wayne State for additional resources. And I think the biggest piece for us that was really helpful in rolling forward with the initiatives has been having meetings with all of our partners in the community. So working with the probate court, working with the judges, working with the public defender's office, working with all those partners to get our process clarified amongst all of those moving pieces. There's a lot of timelines and requirements that are quite challenging to manage as a CMH and a hospital and the court system together. And so, going to those resources to get the information, but then really building the relationships with your partners and then sharing whatever you have for customers has been critical, because there just isn't a manual that you can hand over and follow step 1 through step 12. So.
Thank you. Jennifer, what would you add?
I agree with both of the resources. And then the other thing that I would add is looking at the Michigan Mental Health Code and using that as a frame of reference. So when we started, we grabbed the Michigan Mental Health Code and we read it, and then we brought all the key stakeholders to the table and we had meetings about, okay, how are we going to meet these criteria? What processes can we do to try to come up with a action plan to be able to follow?
Excellent. Thank you so much. One of the questions that's also repeatedly come up revolves around staffing and who in the emergency department is kind of optimal to handle this. Do we need to be working to see increases in any specific type of staff role? I'll start with you, Jenny. What would be optimal in this situation? And keeping in mind that obviously we know hospitals in rural areas don't necessarily have even enough staff to do what they need to do already and really feel a disproportionate burden from all the challenges we're all experiencing. What would you suggest?
Oh, I would look at the person that assisted with the assessment. So a lot of times for Genesee County, that is the social worker and the ED. That social worker either fills out the AOT petition themselves based off of what they assessed and submits it to probate, and then we're tasked to follow up for the assessment, or they reach out to our AOT program just let us know what the concerns are for us to follow up with that individual. But somebody, either a registered nurse or a social worker that met with the individual and knows the person well enough to present all of the concerns of why that they're looking at seeking an AOT.
Thank you. Sojourner, what would you add?
I know that there is a shortage of just good help and master level clinicians anyway. However, we have to look at those non-traditional fields to be able to assist with engaging our members, and they would come across them anyway. And so when I say non-traditional, I'm talking about people who may have a master's in public health or even a criminal justice background, because they're not technically billing. And so they're linking, coordinating, and following up. And so maybe those might be some other avenues to gain additional staff. We just got to be honest, people aren't coming in our field. And so, but there's plenty of work that still needs to be done. So I would suggest reaching out to those type of platforms as well.
Dr. Field?
Yeah, within Calhoun County, we rely very heavily on healthcare advocates and peer and recovery coaches. They're doing a lot of the outreach and engagement, working alongside our case managers and supporting our psychiatrists' efforts, just because there's not enough time on the other personnel. So we use those two positions. We also have under our grant team a monitor, as well as a sequential intercept coordinator for the county that can work with those peers and those healthcare advocates to assist in navigating engagement with law enforcement, engagement with the hospital systems, and then of course how the court would like to proceed with different challenges that we're seeing. But really it is those healthcare advocates and peers that play a major role in this for us.
Thank you. On a personal note, I know that many of the participants have wondered if it would be helpful to get more social workers in the ER. And obviously, I think this is a good thing. But similar to other professions, there is a substantial shortage of social workers right now. And I can tell you, especially being a professor in a new master's level program, that students are interested. We know that we will have more people entering the field, but there's going to be a big gap. And so I'm encouraged to hear some of the suggestions, especially how a relationship with the local CMH can address many of the questions that we're talking about here. And it's worth noting that a lot of this is brand new to everybody. So this is a great, real synergistic opportunity in a webinar like this to really exchange ideas and start moving the conversation forward. Again, if you have other questions that come up outside of the webinar today, you can go to the website and actually post those, and we will be continually monitoring that and taking that to the larger state level initiative and stakeholders. One question that was coming up was really around the involuntary nature of assisted outpatient treatment, and obviously the concerns we have anytime we impose restrictions on somebody's liberty. Are CMHs actually empowered to advise against an AOT? So somebody petitions the court, maybe it's a hospital, family member, law enforcement, somebody petitions for an AOT. There's going to be an evaluation at that point. Can the CMH recommend against that? Dr. Field, I'll start with you.
Yes, they can. When they get involved, they can absolutely provide their recommendations. I think that's the importance of the relationship we have with the court. So we know every AOT that's coming through, every request or petition. As the CMH, in fact, the guidance given by our ED, our law enforcement, and our court is that if you want to petition for AOT, you do that through the CMH so that we can really coordinate services prior to that happening based on evaluation or resource navigation for the family. So yes, you can push back as a CMH, but once it's been ordered, it becomes a little bit of a balance to have that dialogue with the court and have your evaluation recommendations that come back, giving new direction to the services or what would make the most sense for that individual.
Thank you. That's helpful to know. And again, it's important that the system has good checks and balances and ways to more effectively ensure that everybody receiving services has their rights honored and retains the autonomy we know is necessary for the maintenance of their illness. And one of our participants, Jennifer Higgins, makes an excellent point, and I just want to reiterate this. If we understand AOT is a tool as opposed to this enforcement act, rule, law, I think it makes it much easier to conceive of it as part of our overall strategy to address some of the challenges we experience with a ever increasing, population of people with mental health challenges. So yes, AOT is a tool. It's one of many tools. And in the same way that we probably don't want to just use a hammer to fix everything around the house, we don't want to try to use AOT to try to fix it. We only have a couple minutes left, but there's one question that I personally want to hear an answer from our panelists. And that is, I want to know, what would your dream be? What would you love to see down the road? Maybe as in part a result of AOT, in terms of how EDs will function and the role that they'll play in the future as a result of AOT. Jenny, would you answer that first?
I think my dream would be that the CMHs and the hospitals and any other stakeholders have a real collaborative partnership and approach to helping these individuals. And so then we can work together to get anybody the treatment that they need, to gain insight into their need for mental health treatment, and help them avoid recidivism, avoid going back to the hospital, and further decompensation of their mental status. So really working together to help the consumers live their best life. And if that means using an AOT short term to get to that point in the long run, that is, like you said, one tool that we could use to get there.
Thank you. Soja.
I would have to piggyback on Jennifer, realizing that they are all of our members and that we can't serve them in one capacity and don't include the other. And so however we can come together to collaborate, coordinate, link the member to what they need at that time and work with them as opposed to doing things for them. I think that it will make all of our jobs a lot easier. I say all day long, I'm working every day not to have a job. And so that's what my wish would be. And as long as, I'm in this position, I really try to be that conduit, but I am just one person. So that's what I would like to see happen.
Thank you. And that's our time today. I want to thank everyone again for joining us. As a reminder, you'll find a recording of this webinar and many other AOT resources in the AOT Toolkit, which is located on our website at behaviorhealthjustice.wayne.edu/AOT. And any questions that were answered today that we didn't have a chance to get to are going to be shared with our larger AOT work group. Based on the feedback given, we may make adjustments and additions to the online toolkit content or frequently asked questions page. Don't hesitate if you have additional questions or feedback about the toolkit, or just would like to share your story, please submit it through the toolkit website. Thank you again and have a great rest of your day.